internal height is small, naturally the child will follow the mid path. It will be smaller height and it is normal. Second is constitutional delay. In that case, the exact cause is not known. After investigation, you cannot find what is the cause of short stature. But after birth, the child grows normally up to 1 year, and gradually the growth rate decreases. But during puberty, due to pubertal growth spurt, suddenly the height increases and it may make up the mid-parental height. Then disproportionate body feature, that is upper segment or lower segment ratio is not equal to 1. That is achondroplasia and rickets and hypothyroidism because of short limbs. Then proportionate, but the growth failure occurs from intrauterine, like prenatal conditions. These are IGR babies, Down syndrome, Hermann syndrome, and Russell-Silver syndrome. In this case of Russell-Silver syndrome, it will simulate like your growth hormone deficiency, but the head size will be normal and there may be asymmetry of the limbs. It is a chromosomal defect of chromosome 15. Then proportionate postnatal onset of growth failure. These are developable conditions like malnutrition, tuberculosis, malabsorption, hemolytic anemias, renal failure, congestive heart failure, congenital heart disease, growth hormone deficiency, hypothyroidism, Cushing syndrome, and cystic fibrosis. This is the algorithm one should follow while diagnosing a case of short stature. Regarding the investigation, I have already enumerated. You have to go step by step, and MRI of brain, IGF-1, IGF-BP3, and growth hormone stimulation state. And if there is any dysmorphism, then go for karyotyping. Then growth hormone therapy monitoring. After growth hormone therapy, the rate of rise in growth occurs, height occurs 10 to 12 centimeter per year for first 2 years. Then it gradually declines to 6 to 8 centimeter per year, and then it follows a normal pattern of growth. What are the causes of growth hormone deficiency? It may be congenital, genetic defect, or acquired defect. The congenital defects are septo-optic dysplasia. Case develops from frontal, maxillary, and mandibular process which fuses together. If there is a midline defect, that will give rise to midline defect, developmental defect of the pituitary and hypothalamus, and that is the cause of congenital septo-optic dysplasia, giving rise to different kinds of short stature. Then genetic defects. Genetic defects may be autosomal recessive, autosomal dominant, or sex linked. Because growth hormone secretion depends upon hypothalamic factors, development of pituitary, and also response of the target organ to the growth hormone. The pituitary develops from oral ectoderm as an invagination and to the Rathke pouch, and gradually gets separated and grows individually. There is some transcriptional factor which is genetically determined. That factor differentiates this ectodermal tissue to 5 types of cells. That is somatotroph, which produce growth hormone, lactotroph, which produce prolactin, gonadotroph, which produce gonadotropin, corticotroph or corticotropin, and thyrotroph, which produce TSH. So if there is any differentiation between during this cell structure, either it will be produced subnormally or it will be absent. In this case, there is a hypoplastic pituitary, so all the hormones are produced minimally. And according to the cell mass, this growth hormone cell, that is somatotroph, constitute 15 or 50% of the cell mass of the pituitary and the pituitary. And also, these hormones are controlled by hypothalamic releasing and inhibiting factors. They are also genetically controlled. If there is any genetic defect, so the releasing and inhibiting hormones may be abnormal, may be absent. Even if the pituitary is normal, the cell types are normal, it will not produce adequate growth hormone. Then sex-linked type. In sex-linked type, it may be associated with some immunodeficiency conditions along with hypopituitary. And the acquired conditions are trauma, tumor, cranial irradiation, and malnutrition. Diagnosis of growth hormone deficiency I have already discussed. Postnatal growth reduction in a proportionate stature. Bone age lags behind chronological age. Growth hormone level less than 10 microgram per ml after stimulation, and there is IGF-1 and IGF-EP are normal. The IGF-EP is insulin-like growth factor binding protein which remains circulated in blood at least for 6 to 7 days. So this is a stable one which we can judge whether the growth hormone secretion is adequate or not. How long we should give growth hormone therapy? If gain in height is only around 1 centimeter per year, then stop growth hormone therapy. It is not responding. It may be so that there may be some growth hormone receptor defect in liver. Even if there is growth hormone level is normal in the blood, it is not being converted to IGF-1 and it is not effective. That is the Laron syndrome. Then attainment of acceptable height. When the child attains acceptable height at the mid-parental height, at that time it can stop. Or time to time assess the bone age. When a male child attains a bone age of 16 years or a female child attains a bone age of 14 years, in that case stop growth hormone therapy. These are the other conditions where growth hormone is used, as Turner syndrome, renal failure, small for gestational age children, idiopathic short stature, and sports injury. In sport injury, they say that it accentuates healing. That's a growth hormone is used. In Prader-Willi syndrome. The management is growth hormone therapy at a rate of 0.23 to 0.3 milligram per week in divided doses, but some people to give at a lower dose to see the response, and gradually they attain this normal level, and to treat the associated condition with adequate calorie, protein and vitamin. Thank you. This is the photograph of Messi, which is a renowned football player having growth hormone deficiency, and he is already on growth hormone.